Hey, good afternoon, everybody. This is Tom Reck. I'm a partner at Withum, and I'm a member of the Forensic Evaluation Services niche. As a result, I spend much of my time either performing valuations of practices relating to buy-sell agreements, litigation matters, etc., or I oversee the forensic analysis of practices to determine if funds have been defalcated, billings improperly performed, etc. It's a pleasure for me to present with someone as well respected as John today, and I appreciate you taking the time for participating in today's webinar, John. I hope our registrants find today's program useful, and I'd also like to thank Rachel and Allison for their assistance in putting this all together. John?
Sure. Thank you, Tom, and good afternoon, everybody. And I echo my thanks to Rachel and Allison for helping put this together. As Rachel indicated, and as you can see on the screen, I'm the chair of our healthcare department, and that means we represent a whole host of providers across the spectrum, hospitals, physician groups, from the solo practitioner to the large single and multi-specialty groups, to a number of physician specialty organizations throughout New Jersey, Pennsylvania, and New York. And I'm pleased to present this afternoon with Tom. Looking at this picture, you can tell it's a pre-COVID photo, because at this point I'm sporting the typical COVID beard. So we haven't quite updated the picture yet, and how long I'll keep this remains to be seen based upon the advice and recommendations of my wife and my barber. So we'll begin. I just wanted to also remind you we are recording this so that and it'll be posted on our respective websites, both Withum and Brach Eichler, for further listening or viewing pleasure. And also, as Rachel indicated, we would encourage you, as the program goes on, to type in your questions. Tom and I have allocated approximately 40 to 45 minutes of the presentation, and then we will go through the questions that you have posed to us, and we'll try to answer them as succinctly, honestly, and in a helpful manner as we possibly can. Next slide, please. So pre-COVID, the consolidation in the healthcare industry in New Jersey was significant. Almost every other month, we read about a hospital system acquiring another hospital, perhaps a hospital in distress, going out of business. But the hospital merger and acquisitions have ramped up post-COVID, and a lot of transactions that had been put on hold, understandably, because hospitals were preoccupied with dealing with the New Jersey residents and treating them, which is still ongoing, but in a more manageable way. Deals and transactions are going on. Physician practices, and we're going to focus in on that as to what are physicians' options today, whether it is doing a hospital transaction, a Wall Street private equity transaction, or staying the course, or joining a large single or multi-specialty group. We're going to talk about that. The Wall Street private equity M&A work has been interesting to follow. Pre-COVID, there was a ton of activity. COVID really stressed those relationships. Some transactions we're watching them teeter on unwinding. Some have gone out as a result of the pressures. Wall Street not anticipating, not that anybody could, but not anticipating the economic impact COVID has had on the practice of medicine. We're seeing the transactions beginning to re-engage, but the purchase price and acquisition numbers are changing. Next slide, please. So in a medical practice, pre and post-COVID, the overhead associated with the practice is staggering. To what extent reimbursement can catch up to overhead increases is a challenge for most medical practices. We also look at staffing. Physician practices is heavily reliant on its staff to conduct services, and we're seeing a number of issues and concerns regarding staffing in terms of how anxious or how anxiety filled staff members are in coming back to the office. Tom, do you want to speak to that a little bit?
Sure. Staffing has been an issue for many practices. Some have furloughed employees or laid them off, and of those, some have had difficulty in getting their employees to return to work. In addition to that, those that received PPP money have had to deal with a plethora of changes in the rules that have occurred. So what do I mean by that? So for example, initially when funds were to be used, they were to be used over an 8-week period. That was what was known as the covered period. Now the rules have been changed for the funds so that they are to be used over 24-week period. There's an alternate payroll covered period that allows for entities to elect eligible payroll costs that begin on the first pay period after the receipt of the loan. So that's beneficial to entities. Initially, you may recall, of the amount that was received, 75% was to have been used for payroll related costs and 25% for other specific costs such as rent, mortgage, interest, utilities, those things. Those rules have now been changed so that it's a 60-40 split. And the FTE requirements, the date has been moved from June 30th to replace employees that may have been terminated to December 31st, so that if you're back to your pre-COVID levels by the year end, 12/31, then loan forgiveness should not be an issue. So the rules have been changing dramatically, and it's also interesting to point out that as a result of the extension of time for the covered period, the amount that's allowed to be paid now was originally $15,200 and some odd dollars, $85 over the 8-week period. Now that's gone up to $46,154. So the SBA has done what it can to help alleviate the cash flow crunch that's being felt by so many practices in our area. John?
Thank you. The reimbursement continues to be a pressure point for physician practices, which is a driving force for considering alternatives, going with a large or single specialty or multi-specialty practice, or going to a hospital system that can bring lift to reimbursement. So it's a key consideration in this challenged time. Capital investment is also on a pressure for medical practice. Medical practices have to stay up to date and current when it comes to equipment, and key aspect in terms of being current. Those costs can be significant, and physicians and physician practices need to talk to peers or colleagues or look to ways to minimize that impact upon the practice. Managed care contracting continues to be challenging, especially in light of the laws in New Jersey regarding out-of-network, which became effective in August of 2018. The ability to maintain a total out-of-network practice is hard, and does joining a hospital system, Wall Street private equity transaction, or being part of a larger group enhance leverage in that negotiation. There continues to be increasing governmental audits, whether it's Medicare or Medicaid, and we are seeing significant increase in private insurers doing the audits. We're spending a ton of time with our clients getting through that. We find, especially when it comes to the private insurers, it's a form of extortion. It requires negotiation, and there's different ways of handling and those types of audits to the benefit of the physician practice. Let me switch to Tom for a moment to talk about the audits that are going on.
Sure. It's no surprise to everybody the difficulty that is being faced by practitioners today. It's very difficult to work, for example, in a small office when files have to be maintained in certain ways to be in compliance with HIPAA. There's costs associated with compliance with that. There's costs associated with high tech, the Health Information Technology Act. There's, as everyone knows, the governmental regulations associated with the anti-kickback statutes, the criminal actual penalties associated with anti-kickback statutes, the Stark Act, obviously, which is preventing physicians from referring work to entities in which they have a direct or indirect ownership interest, with civil penalties associated with that. And now on the horizon, we've got this whole issue of price transparency. And on top of that, with folks struggling to provide services in a rather tenuous environment, now more and more we see folks getting letters from insurance companies after the fact, looking to challenge payments. So they're looking to unbundle, or they're looking to challenge coding. So those are very common. And I've even had some instances where some folks have been contacted by CMS and been accused of some abuses, which frankly, in one particular case, I don't see. But nevertheless, it's the case, and essentially CMS is looking for a deal to be made. Otherwise, they'll cut the provider off from providing service in the future. From the accounting point of view, obviously, if my recommendation would be, if someone is contacted by CMS, immediately reach out to John or counsel to cover yourself on that. John, back to you.
Sure, thank you. So this is an important feature that everybody should be aware of. As you all know, coding and billing is an art, not a science. And there's a lot of ambiguity and gray zone in terms of the documentation to support a particular procedure or code that you're seeking reimbursement for. Documentation, of course, is critical. And when the government and or insurer is asking for medical records to review, we've oftentimes have seen that the appropriate documentation is there, but it is not found. So you get a letter saying, okay, we found of the 100 charts, X number were incorrect, there was no documentation, and the government and the insurers are able to use an extrapolation methodology to determine how much of an overpayment needs to be refunded. And a lot of times the appropriate documentation, I said, is there. Depending upon the amount that the government or the insurer is seeking to reclaim from you, you may, and I recommend you bring in a certified coder to review, because again, they're looking to get money back. There is no sympathy towards how hard you work and how many hours you spend not only seeing patients but handling the paperwork that's necessary to run your practice. So depending upon, again, it's the amount of the recovery, it's worth investing in a coder. Typically, counsel retains the coder directly to maintain the attorney-client privilege, and then we're off to the races to negotiate something. The government and the insurance company are always willing to negotiate. In fact, when it comes to the private insurers, the person who's lead on the particular matter is incentivized to get a percentage of what is recovered. And it's almost like dealing with when you're buying a car and you're negotiating with the salesman, they always have to run to the manager to get approval. Well, these folks, they go to their supervisor to get approval. But negotiation is the way to go. You need to have the facts, you need to have the information. But again, this is going to continue to go on. On any given day, we probably have close to a dozen audits among all the different payers going on. Don't just write a check. Get outside input and support in order for you to keep the money that you've worked very hard to get. Next slide, please. So post-COVID, what are the physician's options? Status quo, just keep doing what you're doing. Maybe you ride it out to the next wave because everything has changed. And if you've been practicing medicine in the last 15, 20, 30 years, you've seen multiple changes, but you keep your head down, work hard. It's not an easy thing to do, but you can kind of tough it out till we get to the next wave. Others want to bring in other physicians and grow it organically. You employ a physician, that physician matriculates to co-ownership, and there are a lot of advantages to that to the senior physician. Hospital affiliation is very popular. Hospitals are willing to pay for practices, not a lot, but they're willing to take over the responsibility for the administration, management of the practice, and we'll get into the detail, create economic incentives, and presumably, all things being equal, you'd make more money in a hospital situation than continuing on to the practice. Mergers with other practices, again, where we have the Summit Medical Group, we have Advocare, there are other large multi-specialty groups throughout the state. Some are physician-owned, some have private equity backing. Riverside is another one I should mention. And we've also seen the development of large single specialties. The urology group that was formed a couple years ago is very large. Again, they have private equity backing. There are talks of large GI practices being formed, orthopedic. No specialty is immune from this, and everybody should talk to their colleagues to see if 1 + 1 could equal 3. And of course, private equity from the Wall Street, where physicians can really monetize their practices, but there are clearly pros and cons of that, and we'll discuss what those are. Next slide, please. Well, why do this? Unless you're going to make more money, it's not worth it, because it's going to cost you money to get there to the finish line of a transaction. Administrative support, again, a lot of physicians have grown weary of seeing patients all day and then working till 10 o'clock, 11 o'clock at night to handle all the admin. They're ready to hand it off and let someone get the gray hair for working on this. Retirement options, then at the end of the rainbow of practicing medicine, are there better ways to cash out at that particular point in time? And some of these transactions provide those options. Next slide, please.
Okay, so we're on to our first polling question. Have your patients been reluctant to come to the office? All right, about 15 more seconds to submit your answer. All right, I'm going to go ahead and close it out, and here are the results.
So 38% are saying yes, 24% no, not sure, 38%. You know, it's interesting. I've been hearing various answers on this question, and I think a lot of it has to do with the health of the patients, elderly patients, people with compromised immune systems. I'm hearing obviously do not want to go to practices. Others are not so concerned about it, and I know many of our clients are actually having their patients wait in the car and then get a telephone call as to when they can come right in and be seen. So those results don't surprise me. John?
Thank you. So how will the practice change? So if you're in practice, you have your corporate documentation, if you're an LLC, you've got your operating agreement. If you have your shareholders agreement, if you're PC, you have a shareholders agreement. You need to review these documents to see if they are now reflective of the current and foreseeable future work environment for your practice. When we get to distributions and compensation, is the base salary appropriate for the new world post-COVID? You know, there's basically for physicians 3 ways of compensating a doctor. We pay a straight salary, or it's 100% productivity based, or it's a blend. We give everybody a draw, and then everybody can get a bonus production. It could be a 50-50 split. I've seen it 20-80. I've seen it 80-20, and everything in the middle. But does that still work for you? Tom, a little bit on work RVUs and compensation.
Sure. So most of what I'm seeing is physicians are being compensated on their work RVUs. And to John's point, sometimes there's a mix. So there's a base of a certain dollar amount, and then productivity on top of that calls for a true up at the end of a quarter, at the end of a year, whatever time frame it is that's selected. And obviously one of the driving factors here is, in addition to Stark and AKS looking for compensation to be based on personal productivity and not payments of referrals, for example, there's this whole idea of the practice itself looking to fairly compensate the employees. So the physician practices typically want a reward for hard work, and as a result, physicians are paid based on the productivity, some sort of blend. Pure productivity only works if the practice carefully tracks its RVUs, and that's something that we bump up against quite a bit. There is issues with how well those are tracked. Now, the obvious issue is going to become moving forward. If gross revenue is down, obviously the WRVUs will be down, and any compensation available to be paid will be decreased from the pre-COVID levels. So that's something that obviously everyone is having to deal with. When it comes to bonus arrangements, which is something that you see here, item number C, bonuses can be based on productivity or some other metric. So for example, I've often seen compensation given for quality of work, good citizenship, as we call it, relating to patient satisfaction or participation in organizational initiatives, that sort of thing. So it's a combination. I think at the end of the day, though, at least for the short term, as a result of COVID, compensation is going to be negatively impacted. John?
Yeah, agree entirely, which is why the base, you need to think about amending the agreements to alter base salaries in the event we see this type of thing again. It really kind of keys into number 2 here, employed physicians. So when things began to hit and practices began to either shutter or reduce significantly, we received a number of phone calls. We need to terminate Dr. Smith, or we need to terminate or modify Dr. Smith's compensation. Well, in most practices, Dr. Smith has a contract, and most likely the contract cannot be unilaterally amended by the employer from a compensation standpoint, or even hours. And typically the force majeure provisions, act of God provisions, did not necessarily relate to this particular situation, as evidenced by many practices seeking business interruption insurance, where the insurers are denying coverage, but that's for another webinar. So I would say, well, does Dr. Smith have a contract? Yes. I said, well, you can't just unilaterally reduce his or her compensation. So what we began to do and recommend is, look, everybody's well aware of what's going on in the world, especially physicians. You need to sit down with your physicians, with your partners, and say, we need to alter compensation or we're going to go out of business. And most physician practices handle it in a transparent, upfront, candid way. And almost every physician employee reluctantly agreed and acknowledged they're going to have to do this, like the employers and the partners who were taking a lot less money because of what was going on. But we all need to consider now, in light of what happened, in light of the fact that this may not go away too soon, or there could be another situation, you need to think about amending or modifying the agreements to allow the employer to make compensation adjustments, as well as work hour adjustments, and or the ability to terminate the agreement if the office is working at below X% capacity. Now that takes you into the world of the enforceability of the restrictive covenants, but you really need to begin to think about preparing your documents not only for the owners but also for the employees to take into consideration future changes. Next slide, please. Let's talk a little bit about how the Wall Street structure works. So in New Jersey, we have a corporate practice of medicine statute, which basically says in order to practice medicine, you either have to be a physician or you have to be licensed to provide healthcare services. And those licenses typically come from the Department of Health. But not every type of provider or non-doctor provider can get a license to practice medicine. Some cases it's possible, some cases it's extremely arduous. So what happens in New Jersey, the private equity firm identifies or has a physician that they can, in quotations, control, and the physician is going to sell the practice to that physician owner and sell the non-clinical assets to another company the private equity company owns. We get into, of course, how to value all of this, and the valuation is based upon two moving parts. One is what is the EBITDA number of the practice, which is considered, for lack of a better term, and Tom can correct me and be more precise with the language, basically the profit. And then that number is then multiplied by a factor. And the multiplier or the multiple that's used in practices can range from a low of 3 to 4 to some as high as 10, 11, or 12 we've seen. But those multiples are very dependent upon the specialty, the size of the practice, the geographic location of the practice, as well as an intangible valuations as to who the players are in that particular practice, how old or young they are. And that's the basis of these transactions. But I will tell you that when you sell the practice, you're selling the profit of the practice. So let's say the physician's compensation owner is about $700,000, but the MGMA standard for that physician in that area is, let's say, $400,000. So $300 is deemed the profit, and the physician compensation then gets reduced going forward by the down to the 400 level. So you're basically giving away your money or selling your money to the private equity firm, so that depending upon how long your horizon to practice is, it may not be worth it. If it's a 5 to 7 year horizon, depending upon the multiple and the EBITDA, you can make it work. But if you're working for 10, 15, or 20 more years, the math will never work. Next slide, please. Hospital systems, so they're looking to either lease the practice or employ the physician. They are typically not paying for goodwill. They will pay for medical records, but because of most systems in New Jersey are not-for-profits, and because the physicians tend to refer, there needs to be a fair market value appraisal of what the hospital will give a physician in this type of a transaction. Tom, talk about fair market values, please.
Sure. So to John's point, if a hospital is to be purchasing a practice, it cannot in any way look like it is paying for any sort of referral base. So obviously, if it is to acquire a practice, it has to be at fair market value. Now, what's interesting as a result of COVID is the amount of work that needs to go into understanding the future. What do I mean by that? When you're valuing a business, you're not looking at past results, you're looking at what the future holds. So typically what will happen is the practice that's being purchased will be analyzed starting with the top line revenue figure and an analysis of what drives that revenue. Again, that's forward looking. The revenue by provider will often be analyzed to determine who the more productive members are, as this will feed into the reasonable compensation adjustment that John referred to. There will also be an analysis of the underlying expenses associated with the practice. So there might be an adjustment for non-recurring items or items that are discretionary in nature, such as perquisites, rent that might not be at arm's length, that sort of thing. Dealing with circling back to compensation, one of the components of the valuation, as John referenced, is the determination of reasonable comp. In other words, what would the compensation be that would expect to be paid to someone for the work they perform and nothing else? And in terms of determining the value, the reasonable compensation adjustment often affects the bottom line most significantly. So, for example, if net income was $50,000 before a reasonable compensation adjustment, but $500,000 after a reasonable compensation adjustment. And in each case, we assumed a 5-time multiple. To John's example, you could have a value of anywhere between $250,000 to $1,250,000 based on that example. So, you know, that's something to keep in mind. It's a process that is pretty complicated as a result of the compensation that is being paid to the doctors versus what should be paid to the doctors. John?
Next slide, please. So here, as Tom was saying, you know, compensation is going to be subject to a valuation. We've seen in almost every hospital transaction, they go out to one of several different valuation companies. There's Sullivan Cotter, there's VMG, there's healthcare appraisers, and they do this analysis. And they say, okay, based upon this analysis, this is what we've come up with in terms of your compensation. Rarely do the hospitals share with the physician practice this analysis. And it's always negotiable up to a particular point in time. And the valuations for the acquisitions are also never disclosed. So it is negotiable. Don't accept what the potential buyer, whether it's Wall Street or the hospital system, presents in the first offer. You've got to be aggressive, but it also depends upon what kind of leverage you have, what you're bringing to the table to get what you want. If you're a solo practitioner, and depending upon your specialty, you may have challenges to get that number higher than what's offered. But if you are a specialist or you have a large practice and you have multiple offices and your catchment area is large, you have a little more juice in that negotiation, but you want to push for it. The other key is, and under 2A here, if you don't meet your RVU targets, you may need to take a reduction or you may have to repay advances. So when you're negotiating a deal and they're tying it to the number of work RVUs you're producing, you have to understand, are these work RVUs targets achievable? In a COVID world, they were not. So we now have to negotiate these a little differently to the extent it's going to take time to get back to perhaps where you were, if at all, depending upon patient volume and the throughput in terms of how practices operate, or we need to take into consideration some type of safety valves if things change beyond your control. Next slide, please.
Actually, John, can we just stick with that for 1 second?
Sure.
With the compensation for item number 3, to John's point, typically what will happen is when we look at compensation, we are looking at third-party sources. So, for example, you know, as John mentioned, MGMA, for example, the compensation that's contained in those surveys is generally correlated to production, area of specialty, geographic location, years of practice, etc. And the data can be very specific. So, for example, the items from the survey might include things like gross charges, adjustments, adjusted charges, charges per RVUs, physician FTEs, etc. So that helps us to give a range. As John said, you know, you don't accept the first offer. That enables us to give a range. So, for example, you know, you might look at just the median, for example, and say that if someone was to be paid $60 per WRVU and they produce 6,000 RVUs, they would be entitled to $360. Well, maybe if you did the mean instead of the median or some other form, maybe that $360 is up to $450 or something along those lines. So it behooves someone to really look at the underlying analytics associated with the practice. Back to you, John. Sorry.
Thank you. Nope, that's great. So when you in a transaction with a hospital system, you're going to have a restrictive covenant, and post-termination against going with another system or large medical groups, the restrictive covenants tend to be geared towards, you know, joining a group with more than so many physicians. They don't necessarily mind you going back to the way you were, which is hard, but they don't want you to work with a competitor, and they're now viewing these large medical groups like Summit, like Riverside, like Advocare as potential competitors. You want to negotiate that. If the hospital is going to terminate without cause, there shouldn't be a restrictive covenant. If the hospital breaches, there should be no restrictive covenant. If the hospital fails to renew the employment agreements, there should be no restrictive covenant. But again, these covenants need to be looked at. In New Jersey, restrictive covenants for physicians are legally enforceable. And there have been a number of cases before the New Jersey Supreme Court saying that, so long as the covenant is reasonable in time, post-termination time, and geographic scope, whether it's 5, 10, 15, or 20 miles. And every situation is a little different. You also want to negotiate as part of that hospital transaction. If the agreement terminates, you're able to buy back your assets. You're not going to be able to start from scratch. And we've also had some situations where not only do you get to repurchase, but there's in essence a breakup fee, because to restart what you had in the beginning is going to be costly. Again, that type of termination fee is going to be based upon the size of the group and or your leverage in the beginning of the negotiation. As with all contracts, we hope for the best, but we have to plan for the worst. And it's not uncommon to see transactions where, okay, we promised you X dollars per RVU for the first 3 years, and then now it's time to renew at the end of the 3 years, and all of a sudden the X dollars per RVU is going down. That is not the transaction you envisioned 3 years ago, and it's not uncommon for these reductions to occur. So you have to think about the impact of the restrictive covenant. You have to think about a repurchase option and how that repurchase option will be valued. Tom?
Yeah, interestingly enough, I've had some situations where there was a breakup. Actually, a physician was an employee of a hospital group for a period of time, and then at the end of that time was able to go back out into practice. And one of the interesting issues was the value associated with the doctor at that point in time, and given his age, what the potential value would be based on future income. So it's also interesting too. I'm sure you look at the ages of the participants when they enter into these contracts.
Next slide, please. So the advantage of some of these deals, again, is with the leverage with the payers. We have seen it work effectively. It does take some negotiation. And then we also, are there antitrust issues? And depending upon how it's structured, you will have antitrust. If you're coming together in a loose federation for the sole purpose of negotiating with the payer, you're going to have a problem. There has to be a significant amount of practice integration to get past some of the antitrust guidelines. You can have divisions, you can have profit centers, you can have care centers, but there has to be a certain level of sharing of risk and overhead to show that you do have a group practice, also to get past some of the stark issues that Tom mentioned before. But you have to show a reasonable amount of integration to be compliant from a regulatory standpoint. Next slide, please. Financing is more available in a larger group. You are able to share in the overhead. Again, I made reference earlier to capital equipment, capital acquisitions, whether it's EMR, et cetera. You can, if you're in a multi-specialty group, you can share in the revenue based upon your referrals. Again, you can't, if you're an orthopod and you have X-ray as part of it, you can't get a bonus based upon every X-ray you order, but you can share in a ancillary revenue pool and you can share in that so long as it's not related to your referrals for those ancillary services, be it imaging, lab work, PT, etc. Next slide, please. Disadvantages. This is the one that probably Tom and I spend the most time counseling our clients on. When you are part of a hospital system, when you are part of a large medical group, when you are part of a private equity Wall Street transaction, you are no longer in charge. everybody promises, oh, you'll have the same amount of input as you always did. That does not happen. You have to be emotionally and mentally prepared to give up the reins of control. Maybe you'll be consulted with, and maybe we negotiate certain key elements of the transaction going forward where they can't do certain things without your approval, or they can't do certain things without substantive conversation. But you're no longer part of the decision-making authority. Again, there is some negotiation available depending upon the transaction, but you have to be comfortable with that. I had a number of clients who, depending upon the weather, day of the week, they go play golf. When you're part of a large corporate institution, you've got to meet your RVUs. The office is open. We're paying staff. You got to be there. If you want to have vacation or time off, it's got to be decided so many weeks in advance, and there's going to be much more structure. And a small practice for physicians, like a small practice for lawyers and accountants, you have a lot of flexibility to do certain things, and depending upon how long you've been doing that, it's hard to get away or change that type of work-life balance. Next slide, please. We can skip the next and get to the rolling question number 2.
Okay, on to our second polling question. Do you think practice sales to Wall Street / private equity is a positive trend? All right, about 15 more seconds. Okay, I'm going to go ahead and close it out. And here are the results.
13% yes, 55% no, 33% not sure. Assuming the no's is related to the debt that's being taken on as a result of the transaction and whether the entity will be viable in the long term. That would be my thought process anyway. Okay, let's move on. Thank you.
So I guess we timed that polling question well for the next part here. I also hear from physicians, Tom, and part of that polling question could be the influence of corporate America on the provision of healthcare services. I know that in the early weeks of COVID, when many practices were shutting down or reducing their hours, the ones that were related to private equity transactions were forcing the physicians and staff to remain open, notwithstanding the risk. They needed the money to fuel their debt, and was that the right decision for their staff and patients? And so next time we do this, we can ask maybe a little more granular to hear what people seem to think, but the timing of that question in light of where we're going now was well placed. So what are the advantages? There is, again, some security. There is no overhead. There's potentially increased resources, and that's what Wall Street is showing. Next slide. However, these contracts are not necessarily long-term. And depending upon the structure, if you're an owner selling, you possibly have an opportunity to use a percentage of your proceeds, and it's really not an option. Usually, if based upon the deal, 70% is cash at closing with certain reserves, and 30% is deemed rollover equity into a new management company. The management company of which is the conduit by which the money from the practice gets filtered to, in essence, the private equity management controlled company that the physicians also have a stake in to keep them to have skin in the game. The theory being that as this group gets bigger, private equity is going to sell either all or a portion of that MSO to another private equity firm. So you're able to kind of theoretically get another bite at the apple in terms of a liquidity event, which would be sold at a higher multiple than you sold your medical practice for. How realistic is that? or is this just a figment of Wall Street's imagination? Those types of second and third liquidity events have occurred. They have not occurred a lot, and what we're not sure about is to what extent will COVID impact those successive liquidity events. We've seen the practices that have been very active is anesthesia, emergency medicine, radiology, ASCs. I mentioned before urology, dermatology is big, GI is big, physical therapy is big, so it's continuing to grow. Next slide. So as I mentioned before, in post-COVID, we've seen physicians who sold their practices this way, who signed contracts, but their compensation be unilaterally and significantly reduced. Was there any recourse? I think so under the contracts because of the reasons given earlier in the presentation, because there were contracts, but most physicians like to be team players, and clearly most physicians saw what was going on, so they went along with the unilateral reduction. Sometimes they were negotiated, but what we've seen in a number of cases that these reductions, and even they've been negotiated, have been open-ended, and we don't know to what extent in some major deals whether private equity will restore the compensation formula. It's not a base salary. No one's getting base salary in these deals. But will the formula be honored going forward? And many of these private equity firms have been reluctant to commit to that. So there's a big risk there. Next slide, please. Now, in a medical practice that isn't doing any of these transactions, you have your corporate documents that will trigger, have triggering events for a withdrawing physician. Death, disability, withdrawal, someone wants to leave, involuntary, someone is terminated for cause, and retirement. And these documents that were drafted by counsel with input from you and your accounts spent a lot of time trying to figure out how to value these withdrawals or buyouts. And if someone is leaving now or a month ago or a month from now, depending upon how that valuation was established, COVID threw a huge monkey wrench into these factors. And it could have been to the advantage of the practice and disadvantage of the doctor retiring, or it could create a windfall for the physician withdrawing, but create a huge cash flow problem for the practice. Tom, comment?
Yeah, it's interesting. We get involved, obviously, from our perspective, and one of the issues that we get involved in oftentimes is what is the date associated with the triggering event, and sometimes that becomes an issue in and of itself. You could end up with counsel arguing over 2, 3, maybe even 4 different valuation dates, and to John's point, that can have a significant impact on value. So, for example, just playing devil's advocate for a moment, let's just say that the agreement stated that the valuation was to be, the last day of the month prior to departure, and the departure date is March 25th of 2020. Well, in that case, the valuation date would be February 28th of 2020. Now, again, this is just for example purposes only, but now let's assume, on the other hand, the agreement states that the valuation is to be as of the departure date, and the valuation date under that, again, is March 25th, 2020. There's a huge impact there because March 23rd was the date that the stock market tanked as a result of everything that was happening with COVID. So again, it's very important with all of these to not only have the everything defined in terms of how value is going to be calculated, but also, please, I must stress the date associated with it. John?
Yeah, so I think we get to the next slide. I think all of your existing buy-sell arrangements in your practices, if they have not been reviewed recently, need to have a wellness check to see if the formulas contained in those arrangements are flexible enough to deal with the COVID crisis we're currently presented with and any future disruptions as a result of the pandemic. So they need to be reviewed and updated accordingly. Next slide.
Right. So, yep, business considerations. So, what's happening now as a result of COVID? One of the things you're going to want to look at is the service or procedures that are being performed, are they discretionary in nature? There could be a very large difference between the importance of someone in pain, for example, going to a doctor versus someone who has, a mole, for example. There's not the same, or not the same perceived, I guess you would say, level of immediacy with a mole as someone who's in pain. So to the extent that there's not an urgent need for it, revenue may be down as a result of that. Can services be provided using telemedicine? Again, to that same example, how many folks do we know are using their phones and taking pictures of whatever it might be and sending it to the doctor? I've done it myself. It's, I find telemedicine to be absolutely very beneficial, great time saving. What are the fixed costs that must be paid regardless of the revenue? So you've got your rent, you've got the costs associated, the lease payments associated with the equipment, you've got the salaries, the related payroll taxes, all of those costs that must be borne regardless of whether revenue is dipping or not. And what is the effect on the solvency of the practice? Does the company now have to dip into some sort of debt? Does it have to use up cash reserves? How is it going to survive through what's currently happening? What effect does the access to supplies have on the ability to perform services? And what is the ability to rebound? Is revenue lost entirely? And I see we're running out of time here, so I'll go on to the next polling question if we could.
Okay, so here is our third polling question. As a result of COVID, have you increased your use of telemedicine? I'll leave this open for 20 more seconds in the interest of time. 10 seconds. All right, I'm going to close it out, and here are the results.
Okay, increased use of telemedicine, 65% yes, 13% no, 22% NA. Okay, next slide. Okay, selection evaluation approach. I'm going to go through this pretty quickly because I see we're running out of time. But essentially, there are three approaches that should be considered: the asset, the income, and the market approach. And again, getting back to the overall considerations, what has happened during the COVID period? Is revenue being earned, and what is the long-term outlook for the practice? Next slide. Income, let's go right to that. The method used can cause very different results. So if you were to use a single period capitalization, which is typically used when past results are expected to be indicative of future results, you could get one result. If you were to do a DCF where you expect there to be a decline in income or profitability for a period of time, that will potentially show a lower value. But that is not to say, by the way, that there's no value to a practice. I think we all expect that at a certain point in time, there will be a return to normalcy, although I don't think we've defined normalcy. There will be a return, and that needs to be captured in any valuation. Next slide. I apologize for rushing. The use of pre-COVID metrics may not render an accurate result. So if possible, you're going to want to try to compare metrics during the COVID timeframe. So to John's point earlier, when he was talking about EBITDA multiples, we've seen EBITDA multiples decrease as a result of COVID. Equity markets have been volatile. Therefore, using multiples derived from a pre-COVID timeframe would likely result in an incorrect result. Cost of capital has increased slightly, and depending on the practice itself, there may be a need to adjust the specific company risk. Next slide. And The next slide basically is let's just say that a single period capitalization was used. There's $750,000 worth of cash flow available, long-term growth rate of 3%. Divide that by a cap rate of 12% gets you to an indicated value of $6.4 million. If we go to the next slide, what you'll see is on the top graph, you'll see that the terminal value, which would be year 4 in this particular example, is $750,000. So there's going to be 3 years of a declined income base. And then in the bottom example, you'll see that the $750,000 income base is not returned to until 6 years out. You can see the impact that it has on value. So it's gone from a $6.4 million value if the money were to be earned today to a $4.7 million value if the terminal value or the return to normalcy is not going to happen until 4 years out, to a $4.2 million value if the return to normalcy is not going to be for 6 years out. So, you know, those are the sorts of things that one would need to consider in terms of the approximation of value, because there is a $2.2 million swing there. Next slide. I did that, I'm sorry, and then let's do the last polling question if we could.
Okay, and here is the 4th polling question. Are you expecting an increase in uncollectible revenue as a result of COVID? About 20 more seconds, we can get to questions.
I know I am.
All right, 5 seconds. Okay, and here are the results.
Yeah, as to be expected, 54% think there's going to be an increase in uncollectible revenue. Yep, 23% no, 23% NA. Okay, very interesting. All right, John, back to you.
Sure. So thank you. You can send us some questions. I know most of you are still with us. We appreciate that. I want to again thank you, Tom, for participating, and Rachel and Allison for working on this for us. As we stated, we did record the program, so it's on our respective websites. And I see there is one question I do want to try to get to, and that is in regard to the HHS grants, no billing of any patient other than insurance or CMS pays already, ? No billing the patient for remainder of invoice or amount. So the question really relates to out-of-network, the impact on being an out-of-network provider. So you do have to commit to not billing in excess of what would be otherwise reimbursed. There are restrictions. The rules keep changing, like the rules were changing for the PPP funds, but there are the limitations on the out-of-network billing. I would direct you to the HHS website for the FAQs to stay current with all of those changes.
Perfect. John, thank you. Thank you everyone for participating today. And I think that
Tom, looks like there's a question for you. Where do you get the capitalization? Yeah, where do you get the capitalization rate, and what is the PV factor referred to?
Oh, so the capitalization rate is something that we develop. Either we do it through what's known as CAPM, capital asset pricing model, or a WACC, weighted average cost of capital. So there's certain databases that we go to that we develop that, and the PV factor is associated with the discount rate that we select. So each year there's a multiple that we would divide it by to get you back to what the present value of that dollar amount would be. And I know it's a little bit detailed, but that in essence is what we do. Is that it on questions? I did not see that one. Okay.
Yeah, I don't see any more.
Okay.
So I guess again, thank you, Tom, and thank you all for participating today. If there's any follow-up, you have our respective emails and contact info. We did cover a lot of material. We wish you good health and safety during these crazy times, and hopefully your practices will rebound quickly and safely.
Thank you.